I'd like to thank the meeting chairs for the invitation, and it's really lovely to be able to talk to real humans, not just faces on a Zoom on my laptop. So thank you for coming, in spite of the travel issues. So my potential conflicts of interest, not quite as impressive as Melanie's, but there they are for you to see. So I work in Cambridge, and this is where I see patients, Lensfield Medical Practice. It's quite an old photo because it's a bit like the catfishing that the photographer mentioned to me earlier. I look a bit older, and we do have flat screens now, and also we have electronic prescriptions, so we don't have this anymore. And that's where I see patients on a Thursday, tomorrow. And if I walk 400 metres or so out from my surgery, I get to the Eagle pub. And the Eagle pub was where Watson and Crick announced that they discovered the structure of DNA. And those of you who know Cambridge will probably know that Sanger and Sulston and all these other people that are very preeminent in the omics world are also from Cambridge. But in spite of this context, and in spite of the application of genetics in secondary care, so in Addenbrooke's now, if you're an acute paediatric admission and they're unsure about the diagnosis, you get sequenced. So in spite of all that, I remain sceptical about the role of omics in GP diabetes care in the next 5 to 10 years, which, looking around the room, is probably going to be, for at least half of you, your remaining careers, like mine. In the next 20 minutes, I want to draw a distinction between personalised and precision medicine. And personalised, I'm reflecting what Melanie was saying about patient-centred or person-centred, and that's what I'd regard our role in general practice, and probably far more important than precision. These words are often used interchangeably, and I want to highlight the benefits of the former, and I want to illustrate some of the limitations of the latter. Now, I'm a strong supporter of stratification. In fact, I published the first diabetes risk score over 22 years ago, and I'm researching the potential for simple risk scores and even genetics to be used in screening programs. So rather than inviting everybody at age 60, we should invite the highest risk people earlier and the lower risk people later, and the higher risk people more often and the lower risk people less often. So I'm very keen on that principle. But I think there is a material difference between stratification, which is a rough ranking of a population, and then so-called precision medicine, which seeks to change the treatment advice that you give to an individual person based on one of their characteristics, usually some kind of omics characteristic. Now, the example from monogenic conditions, such as specific diets of phenylketonuria, and the examples of sulfonylurea for MODY are well known and well described. But the majority of chronic diseases are not monogenic. And type 2 diabetes is a classic example of that. It is a palette of all sorts of pathophysiological mechanisms with underlying genetic and environmental determinants. The same research strategies used for monogenic diseases are not going to deliver similar changes to practice for polygenic conditions like type 2 diabetes. Similarly, the examples from cancer, which has revolutionized treatment, such as the typing of the tissue that informs the treatment, can't really apply to type 2 diabetes because in most cases we don't have access to tissue samples of pancreas, for example. So this is the ADA-EASD definition of precision medicine. So it refers to an approach to optimize diagnosis, prediction, prevention, or treatment by integrating multidimensional data accounting for individual differences. The major distinction from standard medical approaches is the use of complex data to characterize individuals' health states, predisposition, prognosis, and likely treatment response. And I plan to discuss the themes in red here, and whether the so-called precision is actually spurious precision in the case of type 2 diabetes, how readily available simple information that you have in your records is actually far more useful to you than omics technologies in terms of improving the management of patients, and how focusing too much on the individual may actually be unhelpful to the population. And we've just had a vision of the future where 70% of the adult population in the UK who are overweight or obese will be medicalised, will be given semaglutide, and will be coming to see you regularly. we need to focus on personalised as opposed to precision approaches in type 2 diabetes. And in fact, that's what you've been doing for centuries, or we have been doing for centuries, since apothecaries. So firstly, precision, or more accurately, spurious precision. So the thing about the studies of precision medicine is that they often have very large samples from enormous genetic databases. And that means that you have very narrow confidence intervals, which makes it look very precise. But I'd remind you that you can have a narrow confidence interval around a biased estimate. So you can be precisely wrong. And in general practice, it's much better to be roughly right than precisely wrong. I'm going to present a few examples of why I think some of the precision medicine approaches are spurious. So what we currently do is we base our treatment decisions on guidelines and evidence from randomized controlled trials that include trial participants that are hopefully similar to the patients that we see. Often they're not, but hopefully they're similar enough. Much of the science behind precision medicine is based on subgroup analysis of these trials. So we're led to believe that a subset of the sample defined by a particular set of characteristics experiences benefits or harms of a treatment that are much more or less than the rest of the population, that this can be predicted, and consequently these characteristics can be used to adjust the treatment advice that you give to people. Now, such subgroup analysis should be hypothesis generating, not hypothesis confirming, and they shouldn't be the basis of treatment advice. And I'll give you the classic example of why that's the case. This is the ISIS-2 trial of aspirin after a heart attack. And what it showed that was the 1 month survival was 23% better if you had aspirin after your heart attack at 1 month. But if you do a subgroup analysis, which Pato did to demonstrate to the editor of the journal why he shouldn't do subgroup analysis for the trial, if you do a subgroup analysis, you find that if you're fortunate enough to be Libra or Gemini, you get no, if you're unfortunate enough to be Libra or Gemini, you get no benefit from aspirin. But if you're Capricorn, you get a 50% reduction, simply due to the play of chance. So if we need evidence from a trial to inform a guideline and a treatment decision that one drug is better than another, I think we should have the same evidence before we recommend one treatment over another based on a precision medicine approach. In fact, if you look at the meta-epidemiological surveys of subgroup analysis, you find that most of them are not corroborated, either internally or externally. Furthermore, most of the omics type research and subgroup analyses have been done on European ancestry populations. The greatest burden of diabetes and its complications is in non-white populations, even in the UK, let alone the world. And the evidence may not be relevant to those groups. And even if it is, the necessary technology is not affordable or widely available in the parts of the world where diabetes is a greater problem. Next, there's the problem about the design and analysis of these sorts of studies. So much of the research is based on a case control type design. And what that means is you recruit people at the extremes of the distribution of either the outcome, case control, or the exposure. So people who get really good benefit or no benefit from the drug, or people who get really bad side effects or no side effects from the drug. The problem of that is that when you do that, you bias the estimates and you make them look far more optimistic than they actually are due to something called the spectrum effect. And you'll all be familiar with the spectrum effect, because a test that's developed and evaluated and used in hospital, where the prior probability of disease is high, tends to work much less well in general practice, where the prior probability is lower. Next, I want to turn to precision nutrition, which is now a multi-million-dollar industry, and many of your patients may be coming to you having been onto the Zoe app and requesting that you prescribe them drugs to get rid of the yeast in their bowel and giving them tablets that give them a different microbiome, etc. The thing about this is there are a number of assumptions. And the assumptions are that individuals have variable responses to the same nutrition, the same diet, that the responses are reproducible, and that the responses can be understood and predicted by omics and the microbiome, etc. And of course, the microbiome does vary over time, but is often only sampled once in these studies. Now, this elegant work on this slide by Kevin Hall, what it showed is not that if you eat a berry and a walnut quinoa cereal bar, you have a really high level of glucose postprandially. And if you ate a plain bagel and cream cheese and turkey bacon one, you have a low. What this actually shows is the same person with a different meter producing a different response to these same meals. Okay? So we don't know if it's the meter, we don't know if it's the interstitial fluid. We, of course, don't know about the impact of postprandial hypoglycemia after a meal, and we don't know the impact of a particular interstitial fluid, postprandial hypoglycemia, after meals in terms of long-term outcomes. So there's considerable amounts of uncertainty. The advocates of precision nutrition focused on the inter-individual variation. In other words, if Melanie eats a sandwich, she gets this level of glucose. If I eat a sandwich, I get this. So Melanie shouldn't eat a sandwich and I should. That's the basis of it. However, what they don't look at is the intra-individual variability. So Kevin Hall has demonstrated that if you have the same person with the same meal and the same meter 1 week apart, you get very different results. So there's considerable uncertainty still. Now, that's not to say there isn't promise. And there's been one trial published from Israel recently of a machine learning approach that integrates clinical and microbiome data to predict personal postprandial glucose. And they've therefore given people bespoke diets to compare with a Mediterranean diet advice. And they have shown a small, so 0.9 millimoles per mole difference in HbA1c at 6 months, a small difference in outcome. The uncertainty is, does this really tremendous attention you get and this bespoke advice, does it actually make you adhere better to a low-carb diet, which is effectively what it was, than just being told to eat a Mediterranean diet? I think that's the key uncertainty. So watch this space. I'm not ruling out the possibility that personal nutrition may have benefit, and it's certainly very attractive to people who are wealthy enough to afford it. Where the evidence is strong is that there is no, and this is a systematic review that I collaborated with Mike Lean on. Where the evidence is really strong is that there is no single magic nutrient profile or diet that works better than another to lower your glucose or to help you go into remission. The best diet, 5-2, keto, paleo, whatever, is the one that you can sustain. Okay? So this is where we need to think much more about our individuals and our patients and their context. What is it that they could actually sustain to get sustained energy reduction, which is what you need to reduce your HbA1c and reduce your weight in a sustained way? You can't outrun a bad diet, as they say. So this normally divides the audience. I'm now going to talk about interim endpoints rather than true outcomes. The older among us will recognise this as Joan Collins, and she and gynecologists and orthopaedic surgeons were strongly advocating HRT because of observational data. And the trials seem to support that, so HRT seemed to benefit your glucose and your lipids. However, the Women's Health Initiative trial demonstrated that actually HRT might have no benefit cardiovascularly or may even increase your risk. And those of you who are old enough and who were practicing at that time probably had lots of calls from anxious women on the day that this was published. Rosiglitazone is another example that we should learn from. So just because you lower glucose doesn't mean that you'll reduce the burden of diabetes, which is cardiovascular disease. And if we're being person-centered and if we're focusing more, rather than on precision medicine, on personalised medicine, we would be thinking about the patient as a whole. So we'd be thinking about the thing that is really going to matter to them, which is more likely to be risk of stroke, risk of heart attack, risk of premature mortality. And it may well be we want to focus more on the blood pressure and the cholesterol, which have stronger relationships to the outcomes than we do on the glucose lowering. Drugs for lowering glucose actually lower cardiovascular risk via mechanisms other than simply glucose lowering. And so having omics telling us that we should give someone a gliptin rather than SGLT2 because it will lower their glucose more, when gliptins have no effect on cardiovascular disease, whereas SGLT2s do, seems to be rather missing the point. I think a personalised approach would consider a wide range of potentially mutable determinants of disease and disease outcome and incorporate a range of biopsychosocial factors during a shared decision-making consultation. A personalised approach would also consider the relative merits of managing the blood pressure or the statin or the glucose. So when someone with a newly diagnosis comes to see me, I essentially want to get them on 3 drugs fairly quickly because that will halve their risk of events. But putting them on all 3 on that first consultation is a challenge. I think there's been wonderful increases in knowledge from the omics technologies. However, we need to be honest about our ignorance. Most variants are in non-coding regions of the genome. For the most part, we can't link variants to biology or clinical endpoints. We don't know what tissues genetic variants influence and at what stage of the disease trajectory the influence may be important. There are relatively few examples, if any, in diabetes and obesity of gene-environment interactions that have been replicated. So telling someone with a particular gene to move about more or move in a particular way as opposed to someone else doesn't really have a sound basis. Finally, on this topic, Sidney Brenner, who was one of another Cambridge Nobel laureate, he was asked, what was the most important of all the omics? To which he said, economics. And I think we need not only evidence that a precision medicine approach is more effective, we need evidence that it's more cost effective. The next issue that limits our progress in this area is that the people doing these studies don't seem to be aware that people don't take their tablets. So if you're taking metformin and sulfonylurea, according to the DARTS memo, only 13% of patients take tablets as prescribed, which is 95% adherence. Genetic studies of efficacy of drugs and genetic studies of adverse effects pay no attention to this and rarely measure adherence. If they do measure it, they don't measure it with precision. So you're going to get biased estimates. They also take no notice of the placebo and nocebo effects. So we know that if a patient knows they're on a statin, they have a 10-fold increased chance of having an adverse effect than if they don't know they're on a statin. Next, complexity. So humans are beguiled by new technologies, and the health minister would much rather have you adopt a new technology that's sexy than actually enable you to deliver things that we know work in an effective way. So probably the father of that approach is Julian Tudor Hart, who was famous for his inverse care law, but also famous for telling us that a good management of chronic disease like diabetes involves doing simple things well for large numbers of people, few of whom feel ill. If we look at the National Diabetes Audit, we can see that there is really quite a gap between where we are and where we could be. And bridging that gap even a little will make an enormous difference. This is the STENO-2 trial. It only had 160 patients and yet had 2 papers in the New England Journal. It compared conventional treatment of people with diabetes and microalbuminuria in Danish general practice with a peripatetic clinic where they tried to be more intensive. And it produced a 50% reduction in heart attacks and a 50% reduction in premature mortality. You have probably all got more than 160 patients in your practice. So you could look at those 160 and see if we could do any of this, or some of this, we could halve the heart attacks and halve the premature mortality in our practices. And the way to achieve that, I think, is using IT. And I think this is where we have been a game changer compared to 20, 30 years ago. Whatever package you're using, there will be a way of managing your cohort of patients with diabetes. You can rank according to the practices. You can rank your patients according to their HbA1c or their change in HbA1c. You can focus all your efforts on the people with high blood pressure, high cholesterol, and high glucose. So they're the ones that you see. The people with just one of those things might see the practice nurse. You can identify the patients in the target group by just clicking on the links. This is Eclipse software, which is just one of the examples. You can get data on individual patients. You can see why this patient here has gone into a residential home and his glucose has suddenly gone up. And you can present personalised information to patients. And indeed, it says here, no more cakes except on special occasions after admission to the residential home. This tells you what drugs they're on and what they're for, etc. So there have been efforts to subtype diabetes based on GAD antibodies, age at diagnosis, BMI, HbA1c, and HOMA. The former you can get in your practice. HOMA, most people don't have access to that data. But while it was much heralded, actually it didn't predict glycemic progression any more than age alone. The most powerful predictor of drug effectiveness is whether the patient takes the drug or not. And medication adherence is determined not by genes, but it's determined by dose regimen, by patient beliefs, by reminder systems, by the communication and trust with you who's prescribed them the drug. A traditional personalised medicine approach involves negotiating treatment decisions with patients, monitoring their side effects, finding out what's important to them, finding out what are the barriers to them adhering to the drug, etc. HbA1c may be important to some. It may be that blood pressure and cholesterol is more important to you for that individual patient. But why can't you just have that negotiation, prescribe the drug that's chosen, which is a bit more difficult now. It used to be metformin, sulfonylurea, insulin. Now there's a plethora of drugs to prescribe. But once you've chosen one, then simply call the patient back, see if they're getting side effects, and remeasure their HbA1c. That will give you a far more precise estimate of effectiveness and adverse effects than it will checking their omics before you decide on the prescription. And there are ways to help do that. This is the Mayo Clinic Decision Aid. And what it does is it takes you through all the different drugs, and patients can look at this, and looks at the impact on low blood sugar, weight change, side effects, etc., etc. The big omission is it doesn't look at cardiovascular risk, which I think is probably the most important thing. I'll skip that. So, as William Osler said, it's more important to know what sort of a patient has a disease than what sort of a disease a patient has. And the good physician treats the disease, the great physician treats the patient who has the disease. Finally, the individual, or the cult of the individual. There seems to be a misapprehension that giving people information about their risk, be that phenotypic or genetic, leads to changes in those behaviours. We've done a number of trials and a systematic review that shows that is simply not the case. Telling people their risk, genetic or phenotypic, has no impact on habitual environmentally cued behaviours. And of course, the primary determinants of disease are mainly economic and social, and not necessarily purely medical. If we want to make a difference to diabetes, which is a societal problem just as obesity is, we need to shift the population distribution to the left, rather than simply focusing on the few deemed to be at high risk here. Because glycemia has a linear risk with cardiovascular disease, which we're trying to prevent. I'll just switch through that. So how do we do that? How do we shift the population distribution of glycemia, of blood pressure, of cholesterol, and of weight to the left? Well, there are examples of scalable interventions, because I recognise that it's a huge problem, 70% overweight or obese. This is a web-based intervention to help people lose weight, led by Paul Little, and I was a collaborator. And you can see that it does increase the likelihood that people will have a lower weight and will achieve a 5% reduction in weight. Similarly, the Be Well trial, which was from a small provincial university to the west of Cambridge called Oxford. The Be Well trial, what happened in the Be Well trial is that when patients with obesity came to see their GP, often about something else, the GP would remark on the obesity, hopefully in a sensitive way, and would then signpost them to a free Weight Watchers, or any behavioural weight management program, but it was Weight Watchers. And that signposting was thought to be effective. Of course, actually, it was the Weight Watchers that was effective. A GP simply telling you to do something doesn't generally mean that you do it. But again, it does achieve odds ratios of 2 or 2.4 for 5%, or proportion achieving 5% or 10% body weight. So there are scalable interventions that can work. And I completely hear you about tier 2 and tier 3. I have patients waiting for months for this who are very well-intentioned, highly motivated, and not being able to access these services. But of course, as GPs, we're not responsible for the waistline of the population. It's not our fault. And there are a number of different factors, from the collective to the individual, that influence people's weight, blood pressure, cholesterol, etc. William James trained in medicine at Harvard, but he was the father of American psychology, and he pointed out that 99/100ths, or possibly 999,000ths of our activity is automatic and habitual, from our rising in the morning to our laying down at night. You can't have missed the fact that size of portions has gone up. This is a study we did in middle-aged people in and around Cambridge and the surrounding areas. And what it showed is that the number of takeaways that you're exposed to around your home, at work, or in the commute to home and work, and the record was around 140 that someone was exposed to, has a linear relationship with your takeaway consumption and with your BMI. There are only around 10 companies around the globe that produce most of the processed food that we eat, which has an enormous impact on our health. You'll all have seen this, even at conferences for diabetes or physical activity. Everyone is on the escalator, unless you paint a piano keyboard here, and then that makes noise when you step on the step. And then you see that people run up and down the steps making the piano noise. If, like Melanie, you live in a large farm in a rural area of Leicestershire, you have to get into your four-wheel drive Chelsea tractor to get to Waitrose to buy your focaccia bread. If, like me, you live in the middle of a town which is mixed use, so it has workplace, social places, etc., all in the same area, you're more likely to walk and cycle. This is Glasgow. This is Copenhagen. I don't need to tell you which has the higher incidence of diabetes and cardiovascular disease. I think there's a real question about how far administrations are prepared to go up the Nuffield ladder of state interventions. And at the moment, the more right-wing administrations tend to be down the bottom. And we're getting very little of this. Even things like minimum unit price for alcohol, where the evidence is very strong, is not getting through. But also, the cult of the individual and the promise of the shiny new omics technologies distracts policymakers. So it's much easier for the health minister to talk about the investment in new technologies than it is to talk about banning smoking in public places, although that has proved to be a huge success and has enormous impact in the short term, far greater than was ever predicted. But it's much easier for them to talk about funding of new technologies than it is, say, minimum unit price for alcohol. But it also distorts the distribution of research funding. So genomics has an order of magnitude more research funding than studies to try and help people change their behaviour. So to summarise, I think precision diabetes medicine is a hugely interesting field of scientific inquiry. Unlike cancer, unlike other spheres of our work, it's not yet ready for prime time. It's spuriously precise, overly complex, and too narrowly focused on the individual and their glycemic control and not their context. Strategies to inform the selection of glucose-lowering medication that are based on routinely available phenotypic data are showing promise. So the TriMaster trial, which will be published soon, suggests that if you're overweight, then drugs that target insulin resistance, like pioglitazone, might be more effective at lowering your glucose. But I'd still question whether pioglitazone produces as much cardiovascular risk reduction as alternative therapies. We certainly need more trial evaluation, and we need consideration of medication adherence. So while precision medicine is further developed and evaluated, we should focus on improving the application of personalised medicine and treatments and policies that are known to be helpful, on average, for a wide range of our patients. And like Tudor Heart, we should aim to shift the population distribution of blood pressure, cholesterol, glucose in our practice, and weight in our practice populations. And that's likely to deliver far more bang for our very resource-constrained buck than a precision medicine approach at the moment. So thank you for your attention, and I'm very happy to take questions.